This week, you are being introduced to what's known as narrative medicine. Rita Charon, one of the pioneers in the field and the head of the program at Columbia University, has defined narrative medicine as clinical practice fortified by the knowledge of what to do with stories. In speaking of clinical practice, Charon signals that she sees narrative medicine primarily as something that healthcare professionals, particularly physicians, do in their therapeutic interactions with patients. That same focus on clinical practice is seen in a short video called Narrative Medicine: The Power of Storytelling. That short video defines narrative medicine as the practice of mindfully contextualizing a patient's lived experience to better care for them and treat them. Here are some key portions of that little video, which I think you will find quite helpful.
You've probably heard this conversation starter many times before. Tell me about yourself. You might answer with your name, where you're from, and maybe a fun fact. Whether you've thought about these details deeply or not, they lay the foundation of a story that reflects you. The building of this story plays a critical role in narrative medicine. Narrative medicine is the practice of mindfully contextualizing a patient's lived experiences to better care for and treat them. It's an approach to healthcare that considers not only the physical, but also the mental and emotional aspects of a person's health. By seeking out a patient's story, clinicians can gain an in-depth perspective of their patient and ultimately see a whole person, not just a diagnosis. Narrative medicine requires a vast array of skills. Clinicians must be able to listen to, comprehend, and act upon a patient's story. Sometimes a patient's story isn't clear-cut, so clinicians also need to be able to navigate its nuances. This set of skills is called narrative competence, and clinicians can improve their narrative competence through creative expression. Narrative medicine provides a solution to common challenges faced by clinicians and patients. A clinician cannot rely on their medical knowledge alone to prevent, diagnose, and treat illnesses. If they cannot communicate and connect with their patient, the patient may feel neglected, invalidated, or even hesitant to return for another visit. In some cases, a clinician may miss the correct diagnosis, or the prescribed treatment may be ineffective. If a patient is from a marginalized population that has suffered historical, racial, or other categorical trauma, the disconnect can be even larger. Through conversations, narrative medicine can result in more personalized care with improved health outcomes. Researchers at the University of New England found that veterans who were asked to share their personal stories experienced less chronic pain than those who were not. Additionally, clinicians who listened to the stories of veterans experienced less emotional burnout. While there are many accounts of the healing benefits of narrative medicine, there are constraints to the approach. First, there is a limited amount of empirical evidence on the effectiveness of narrative medicine, the training needed to practice it, and how it relates to disease and illness outcomes. Narrative medicine also takes time, and how to manage that time efficiently is a concern for incorporating it into modern medical practices. Additionally, narrative medicine is a tool, not a cure. Clinicians need to understand that using narrative medicine does not guarantee a smooth patient-provider relationship. Finally, narrative medicine cannot fully capture someone's entire story. This stance is known as narrative humility. Initiatives that utilize the approach have sprouted in the United States, England, France, Taiwan, and Pakistan. Medical schools and other healthcare institutions have incorporated narrative medicine courses and workshops into their curriculum and community education, and narrative medicine is gradually becoming part of the Western medical norm.
There are a couple of key points in that video that I want to make sure you understand. The first, notice its emphasis on seeing the patient as a whole person, not just as someone with an illness, injury, or disability. Notice also the claim that a clinician cannot rely on their medical knowledge alone to prevent, diagnose, and treat illness. If they cannot communicate and connect with their patient, the patient may feel neglected, invalidated, or even hesitate to return for another visit. And notice also, if the patient is from a marginalized population that has suffered historical, racial, and other categorical trauma, the disconnect can be even greater. And pay attention to its claim that the practice of narrative medicine requires a vast array of skills. This is what Rita Sharon calls narrative competence, the ability to acknowledge, absorb, interpret, and act on the stories and plights of others. Training programs in narrative medicine and learning experiences aimed at enhancing healthcare professionals' narrative competence focus on the close reading of literature and other texts. The idea is that if professionals learn to pay close and careful attention to texts, that will enable them to pay closer and more careful attention to their patients. What is meant by close reading? Something called a reading guide for reflective practice used at Columbia University asks those learning narrative medicine to pay close attention to things like the perspective or perspectives in a piece of literature. To notice its form or genre. Is it a story, a poem, a play, a parable, for example? And to notice any use of metaphor or imagery and what those metaphors and that imagery is doing in the text. They are asked to notice its diction or style. Is the text formal? Is it breezy? Is it bureaucratic? Is it scientific? And whose voice tells the story? Is it a first person, a second person, or a third person narrative? And what is its mood? And what mood does it produce in those who read it? Training in narrative medicine also involves reflective writing on the professional's encounters with patients and possibly on their own illnesses. Later in the TED Talk by Rita Sharon, she will tell about a particularly difficult patient she dealt with and how she was able to recognize and respond to that patient's need through her reflective writing about that patient. She says, now the way that I knew that, she says, the way I came to understand it is that I'd been writing about her and I'd been showing her what I wrote about her. And in that way, we made contact through her illness, through her fear, through the glare of death that was there now in the room with us, as it always is. But there it was, in the room with us, and we could accept it. Again, the point is, she came to that realization through reflective writing. Encounters with healthcare professionals inevitably involve storytelling. One of the first things any patient will be asked to do before seeing a physician is to fill out a medical history form talking about their past illnesses, their current symptoms, any environmental factors or social factors that might shape their experience of the illness. And one of the first things the physician will typically say upon meeting the patient is, tell me what brings you here today. And the patient will describe their symptoms and what seems to make them better or worse when they first appeared, how their experience of those symptoms is proceeding. The physician will then consult the medical history, trying to put clues together. The point is, all this involves some measure of narrative competence. What the field of narrative medicine is trying to do is enhance that narrative competence by enabling physicians to notice more about the patient and the story they tell than they typically have noticed in putting together a medical history.